I have nothing to disclose relevant to this talk. The reality of the issue is that complications in endovascular procedures is basically a statistics issue. The more you do, the fact that you will get complications. It's not just in the OBL or in the hospital. So it's not based on the venue. It's going to happen. Now, luckily, it's in the single-digit percentage. And as I will show you, luckily it's not that common. Now, the only difference with the venue is that there's really no safety net, quote unquote, with the outpatient lab. Meaning if you have, let's say, a hematoma, there's nothing called, oh, let's watch the patient overnight, because there's no overnight stay. The lab closes at the end of the day, whether 6 p.m., 7 p.m. or so. So you will have to take that into consideration. Now, what we've learned over time is that we do arterial cases and we finish by 1 o'clock, 2 o'clock, thinking that we don't like to start any arterial case in the evening because you don't know what will happen. If there's a hematoma, then we're left basically until midnight or so. So try to limit the arterial interventions until 1 o'clock, 2 o'clock, and then we shift to the deep veins and diagnostics and the like. Just to try to quantify the complications, I chose this paper that talks about femoral popliteal interventions, which is what we do in the OBL. We don't do aortoiliacs. We don't do anything suprainguinal. So, from a femoral popliteal intervention and tibial intervention, if you jump to the complications part, you would see that complications happen in, let's say, within 30 days. For example, there's a 2% to, let's say, up to 10% hematoma, arterial access problems, depending on which reference you read, can go anywhere from 2% to 30%. And that's not OBL, that's all comers, as we say. RP bleeds and femoral popliteal interventions are not common, depending on the access. Pseudoaneurysm up to 2%. Again, all comers, hospital or outpatient. Sorry, hospital. Arterial perforations, depending on the atherectomy, I guess. Thrombosis less than 1%. And, you can get the idea that it's in the single-digit percentage. Now, atherectomy is a common procedure in the when we deal with femoral popliteal interventions, and I've compiled the complication rate, which is perforation rate with atherectomy. I consider perforation kind of the ultimate complication, and it's depending on, regardless of which atherectomy device you use, it has inherent perforation rate. For example, directional atherectomy in the definitive LE trial had up to 5% perforation. Laser had 2%. Rotational atherectomy, 2%. Orbital atherectomy had up to 2.2%. So if you do enough, you will get into perforations. Now that's with the trials, that's with the hospital cases. So in the OBL, we did not have much information, and it was all about anecdotes and personal stories from different physicians, or operators stating their own safety records. But currently, we have more published data. We have now a national registry by the Outpatient Endovascular Society, and I chose two articles that I think Dr. Asher also mentioned. So one of them is from an OBL in Michigan, where they've reported 6,000 plus cases over 5 years plus. And there are all kinds of cases that we do in the outpatient. And the complication rate was 0.8%, which is pretty good compared to what we see in the other complications, just to put it in perspective. The other article that was published later on and is from an OBL in California. And they've reported 5,000 cases, again, all kinds of procedures that we do in the OBL, arterial and venous and so on. But the reason why I picked on this one is because what they've done is they've divided the cases into quintiles, and they looked at the complication rate in the first 1,000 and the second and the third and fourth. and 5,000. And there was an interesting trend, and that's basically is the more they did, the lower the complication rate. So that told us a lot of information. First of all, the number at the end was 0.7 compared to the 0.8 from the Michigan group, which puts it in perspective, which is less than 1%. But it also told us that as they did more, they learned not only more skills, but they learned to go into a case selection situation. So they started picking and choosing what goes to the OBL and what's supposed to be in the hospital. You have to keep in mind that the OBL, or the outpatient lab, is exactly what Dr. Asher said. It doesn't mean that all patients need to be done in the outpatient lab. The outpatient lab is more of a convenience to the patient and to the physician. You know, you control your own schedule, and you think this patient can be done in an outpatient, then you do them in the outpatient. You don't have to necessarily do all your patients in the OBL. So they learned that there are cases to avoid, and then I think Dr. Guja touched very nicely on this subject about the cases to avoid. But the cases to avoid is not just the cases, as he said, it's the cases, the patient, the procedure, and who's the operator. And I think that's what cases to avoid. From a patient standpoint, I think we all know that octogenarians and nonagenarians are a subset of patients that might present you with a problem, even with just simple conscious sedation. If you sedate someone in that age group, then you might run into trouble. Anesthesia risk is another item that you have to keep in mind when you're dealing with patients, regardless of age. High body mass index is always something to think about, because it's not about access, it's about hemostasis. So what's your access point, and how are you planning to close that arteriotomy? Comorbidities, cardiac obviously is very important. We've had patients, and me being a cardiologist, obviously we had some patients that had vagal reactions, had some hypotension, and the algorithm gets into your mind about why is this patient hypotensive, exactly like the patient Dr. Asher presented. Obviously azotemia with all the electrolyte imbalances and the NPO status and similar can also present some other stuff, COPD and the like. Patients who have history of anaphylaxis, you have to be careful. You have to start thinking, do I really need to do this in the hospital, in the outpatient? Is this better in the hospital? Because, do you have an anesthesiologist all the time? Are you comfortable with intubating a patient who goes into a respiratory arrest? And then, there's this item called preference, patient preference or physician preference. And we, sometimes it's a gut feeling. Sometimes you're talking to a patient and you would think that, okay, well, this patient might not be the best patient in the outpatient setting. That's from the patient standpoint. From a procedure standpoint, I echo basically all what Dr. Guja said, but so you have to think of your procedure. Is it, if it's an arterial, is it suprainguinal? Is it infrainguinal? Are you doing an aortoiliac? I mean, we all do aortoiliacs, but when you are in the outpatient lab, the safety margin is very narrow, and that's a very unforgiving territory, meaning any iliac perforation puts you at a very disadvantaged time frame where you're only dealing with minutes before hypotension and hypovolemic shock starts. So you have to be very careful with the aortoiliac, and that's why we don't do any aortoiliac procedures in the outpatient lab. If deep venous procedures, dialysis, obviously, so there are lower risks. So you risk stratify based on the procedure type. Are you doing a procedure with a single vessel runoff? Do you need to put an embolic protection device to protect the runoff? Are you not comfortable with the sizing? Do you need to do IVUS to know exactly what the size of the blood vessel is? Those are all questions come to mind, but they come to mind to the experienced operator. Is there any acuteness to the symptoms? Do you think that there might be an underlying thrombotic event, or do you anticipate any showering of emboli distally? And also, how long is this case? Are you dealing with a flush occlusion of the superficial femoral artery with partial reconstitution at the popliteal, where you're anticipating 2 or 3 hours of work with dual access, antegrade, and pedal access. I mean, those are cases that may be better done in a hospital setting, just at least from a utilization standpoint. From a venous standpoint, is this an iliofemoral DVT where you're anticipating a thrombectomy situation that might cause transient pulmonary emboli? And it happened to us, and we were lucky enough to have this clinical judgment where we saw an iliofemoral DVT, and we've sent the patient, and we did them in the hospital, and despite a temporary filter, had an episode of pulmonary embolism on the table, and with all what that entails from desaturation and hypotension and so on and so forth. So we were lucky to take that patient to the hospital instead of the outpatient setting. Now, as for the operator, I always make a joke of it, but I say the operator should be the chief bailout officer, which means the operator has to be very, very comfortable with dealing with perforations, flow limiting dissections, and no flow situations, because you are in the outpatient. There's no one to back you up. You have to do it yourself, and for that you have to, as an operator, to adhere to the highest standards, not because someone is watching you, or because there's an accreditation body or JACO. It's because you are it. You're in the OBL, and the patient. It's only you and that patient. So you have to adhere to timeout. You have to get your own access. We do ultrasound guided 100% of the time. So 100% for access. Hemostasis with the closure devices. We do it. I do it personally, not anyone else. And then you have to know what's in your toolbox. So in the hospital, we're used to call for atropine, for example, but in the OBL, you have to know where that atropine is, because it's because we take things for granted in the hospital. But anyway, and then you have to know where your covered stents are, for example. So are they the 6 French, 7 French compatible, or are they the 8, 9 French compatible? Meaning you have to know where they are on the shelf, because once it happens, you don't have really a lot of time. Where are the snares, the coils? In summary, I would say how to avoid complications is to know your patient, to know your procedure, and more importantly, to know your limits. Thank you very much.